This non-promotional podcast series is organised and funded by UCB, intended for healthcare professionals in the UK and Ireland.
Welcome to the Let's Talk About Dravet Syndrome podcast series. I'm your host, Micheal Taylor. I'm a consultant paediatric neurologist in Leeds Children's Hospital. In this series, we'll share practical input from specialists and real-life stories from patients and their families. This is to bring you closer to this topic, raise awareness, and empower the medical community to work closely with patients and their families to improve outcomes and quality of life. If you've not done so, please hit the subscribe button so you don't miss another episode. And if you love this podcast series, please do me a favor, give us a rating or review on whatever platform you're listening to us on. The reason we need this is the more positive reviews or ratings we get on those platforms, the more this podcast will be shown to those who have never listened to us before. The aim is to improve the lives of people who have Dravet syndrome.
Today's episode's talking about how to find your adult Dravet patient and why is it important to look for those patients who might have Dravet syndrome. So I'd like to introduce our special guest today, Dr. Rhys Thomas, who is consultant neurologist in Royal Victoria Infirmary Neuroscience Unit in Newcastle upon Tyne and reader in epilepsy in Newcastle University. So Rhys, thank you for agreeing to come on. Rhys and I've worked on quite a few projects together over the last year, and it's great to have you here, so thank you.
No, it's absolute pleasure. Absolute pleasure. Thanks for having me.
So first thing, we know what Dravet looks like in children because it's really well described, but we don't really have a great description of adults. And we know that as pediatric neurologists, we've missed a few diagnoses, and these adults are going to be in your clinics. So what do they look like?
Oh, that's a great question. And it's something I spend a fair bit of my time thinking about. So first of all, I wouldn't beat yourself up for the Dravet cases that you think you've missed. They've ended up in my clinic. I mean, I'll try not to give away my age, but Charlotte Dravet's thesis came out the year I was born. So anybody who's going to be my age or older is going to be missed. And when the infancy of genetic testing in the UK with the Glasgow Centre offering SCM1A specific testing only really kicked in the noughties. So anybody of a reasonable vintage is just going to be labelled as a difficult epilepsy, intellectual disability, multiple seizure types. But then there are patients out there for whom in the adult clinic, it looks just like pediatrics. And that's because we have the oracle. You know, if we've got mum or dad in there and they've got all of the notes, and I've got a couple of people, one with Dravet in my clinic, where they think every drug change, every admission, and probably every seizure on a backed up to the cloud spreadsheet, and they will tell us. You know, I'll say, look, what was the stiripentol dose? And they'll be able to, when it went up, how much it went up to, why it was stopped. So they're the archivist in that individual. Now that's extreme, unusual, but if you're the primary care of somebody with a very challenging to treat epilepsy, maybe you can do that. So for some people, adult Dravet looks like pediatric Dravet because I've got every stitch of information that I need to help to answer that question. You wouldn't have asked the question if it didn't look different, though. So you could flip it to the other end. So I might see somebody who is 40, for whom they're now independent supported living. They may come with two carers who are new to caring for that individual, or at least haven't known them for longer than a couple of years. And they'll say, well, something happened. They were brought into hospital for meningitis, and then it wasn't meningitis. And they were sent home, and they weren't the same again since, and they ended up in special school. And if I'm lucky, I can get hold of the great pediatric notes and look at EEGs and look at how many admissions in the first year of life. But sometimes I'm a bit stumped at that situation, and I may not get a great current seizure description. They may have autism, not like having their head touched for an EEG. I might have to decide whether I put them under a general anaesthetic to get an MRI scan. So I might be scratching my head at that stage trying to work out, what is this? And could it be Dravet?
The seizure burden in adults is also quite different because I know that we face a huge seizure burden in childhood. I believe it's the phrase, the epilepsy burns out. Is that true, or is that myth that we get told or that we extrapolate?
Yeah, it definitely changes, and it's also not the same in every individual. I think the crises are less obvious, and that makes the patients less. Um, they don't present in the same way. They don't present, I mean, literally present rather than the medical meaning of present. So, if you had a young child who still had normal-ish development and they were having clusters of unusual-looking febrile seizures, they would present to the nearest hospital regularly in the first years of life. Whereupon, by the time you've hit 18, 28, 38, maybe these convulsions aren't so prolonged, and maybe people have a Buccal-Midazolam care protocol. They've been well looked after by pediatrics. Everything's looked after in their environment, so there aren't so many crises. I see less status. Certainly see less status. Very much see a lot less myoclonus. Sometimes it's there all the time and not recognised as a seizure type. Sometimes it's not there at all. And I think there is an overall lessening in the totality, the total number of seizures too, and so it loses a little bit of its characteristic punch in adulthood.
I think it's one of the big things is it's going to be really interesting with the Horizon study and the natural history studies coming through about watching that evolution and saying, is it truly a myth, or is it that caregiver concerns change? We know that in the complex epilepsies, early caregiver concern, and this is about all the DEs, really focuses around that seizure burden and managing seizure expectation. And in later life, it becomes about sleep and behavior and those more holistic aspects of care, almost as if the caregiver has moved away from trying to control the seizure and more looking at the wider picture for both the child and their family. So I think that might complement why we also see that difference.
Oh, I completely agree with you. I mean, you get some fantastic parents out there who will say, look, I can cope with seizures. Seizures I can live with. I'm an expert in seizures. I've had 20 years of that. But this new challenge, which might be a new form of behavior, or it might be a sleep issue, that might just be enough that they can no longer go to daycare, or the respite breaks down. And so that's certainly the big issue. And I had that recently. I've got a young man for whom I was thrilled because his convulsive seizure count has really dropped last year. And it wasn't mapped by how excited his family were, because that was my top priority, but it wasn't theirs.
I think one of the big things also in the Dravet population that always strikes me is we know they enter into crouch. So these are sometimes children who've been very mobile. And suddenly one of the great things that they've had is their mobility and that level of independence. And actually, because of their condition, that starts getting taken away. And I think there's some beautiful videos, and I know that Ingrid Sheffer shares them really at a lot of conferences. And it's really, that's one of the things I've actually started seeing in a lot of my teenage patients is they start losing that ambulation, and you're sort of now watching your 4-year-olds going, are there subtle clues that am I going to see this, and when am I going to see it?
Yeah, and so they become bigger. You're more physical. You're aging as a parent. It's more difficult to actually pick them up off the floor. More difficult to perhaps give them that emergency medication. They're less able, and then a lot of the care around them changes. They lose that hero pediatric neurologist who sort of first diagnosed them and looks after them, and then the college perhaps isn't there for them either. So the fact that the mobility changes at the same time is a real kicker, because you will become smaller if you're no longer on your feet.
So you've already really touched upon it. One of the biggest challenges you face is getting that collateral history. But what are the other challenges you would face, and you do face as an adult neurologist, or as we prefer to call you, a neurologist? You don't get the extra title in. What challenges do you face trying to pick up and get those bits of the history? Is it just the collateral history, or are there other elements that you find tricky in sort of identifying these patients?
Oh, that's a great question. I mean, so at a basic level, and it's not unique to Dravet, is some of the hospital systems aren't particularly joined up. So I fought really hard to have access to the genetic testing databases locally. I became a thorn in the side of genetics, so they gave me a password for their database, and I've discovered people for whom I thought they were waiting for a result to come back. It was never sent. People for whom we thought was never sent, and they were sitting on a returnable result. Every mistake that you can imagine. No, it's not common, but you could see it there. And if that's the case for something that's in my institution for which I can get a password, there are hospitalizations that happen 5 miles up the road or down the road that are invisible to me because they're outside of my hospital system. And so when you're trying to collate this information about an individual that comes from ambulance systems and genetics, and carers are trying to collect video as well, no scrap of information is too small not to be important when it comes to care changes. I'll talk about video again because one of the things we talk about is monitoring. That's a form of information that we try and really try to emphasize. And people take all manner of different responses to that, whether it is co-sleeping still with their adult child, or it's I'm fine because I always wake up and they've got the room next door, for which you probably got to accept that. That's worked for 20 years until it doesn't work. Audio alarms, and then people for whom it's now trying to embrace modern technology with wristwatches and equivalent of home security cameras, and they might go and review every night's sleep, looking to do seizure counting every night. That's quite a burden.
So we know about the genetics, and I think one of the big things, we know 85% are SCM1A. This probably adds an extra layer of complexity to adult diagnoses. Is trying to pick up those children, or those adults, sorry, I should say at this point, who have an alternative gene, the Dravet phenotype, and try and marry them across as well. Do you find that's an extra level of challenge?
Yeah, that might always be beyond us. So I've got more experience and more confident in having a surprise SCM1A de novo diagnosis returned to us, and we think, oh gosh, could this have been Dravet all along? One of which, you mentioned the Horizons project before, one of which I recruited into the adult arm of Horizons, and I was saying to Andreas, the lead in Glasgow, look, I don't know what this is. I can't classify it. I know what I previously described this person's epilepsy as, but I don't think it's Dravet. And then as I typed the email to him, I'm thinking, oh, it is actually. It is. I've just sat on it. She's much milder. She's cognitively much better. It can't be anything else. This is just...
We've all done that email to Andreas where we've typed in, we go, I don't think this, and we've all been on that end, and it's really great to have him as a resource. And I'm going to thankfully get another episode with Andreas as well. So I think that is an experience that transcends, I think, both sides, both pediatric and adult practice, that we do have those moments where we're going, it can't be, it's not right, and you're typing it out. I think it's really refreshing sometimes to type that email.
It is. It's great. You've got to have the humility. If you're working on epilepsy, you're going to be wrong quite often. You're just hoping your mistakes are getting smaller and smaller and less over time. The non-SCM1A Dravets are a little bit of a challenge in adult medicine. So I've got a young man I've been involved with very recently whose letters had always said Dravet-like. When the gene change came back, it was very specific for another epilepsy. And so I think it was just Dravet-like, but it was never Dravet. It was a CACNA1A epilepsy, and I wouldn't call that Dravet now. But I've got a couple of individuals who remain unresolved through panel testing, and they've got a very, very Dravet phenotype. They do. A friend's daughter for whom every time she overheats or gets excited, she's likely to go into convulsive seizures as well as other features. And I just can't stop myself from wanting to send the panels over and over again. I know they'll be negative next time, but it feels so Dravet.
It comes down to a very simple fact. Dravet is a clinical diagnosis.
Yep.
And yet we know the gene. We've got we know the typical gene, the 85%, but we know that there are going to be genes within that 15% that we don't know, or there's genes that are very close by. We know SCM1B, or we know I've got some STXBP1s who are very, very close. And I probably will clinically call them a Dravet because the phenotype fits.
Yeah, and I think it's helpful for families as well. And there are going to be technical issues with the way that we test. There are going to be here we go. In terms of what we decide is the standard version of that protein, whether it's canonical or not, will depend on whether we think the variant's within it. And going beyond SCN1A, there are parts of the genome that are really hard to map. So I'm quite happy to acknowledge that there are some technical challenges within panel testing and whole genome sequencing. And I'm not going to wait another tech revolution before my patient gets an answer if Dravet is the best possible clinical label for their epilepsy.
Absolutely. It's one of the big things that I think it comes to is also for adult neurologists, and it was, I think we were in Munich at a talk, and it struck me, one of the things you said to me was actually reminding the adult neurologist to send the childhood panels. So I think it's one of those things very easy. There's, childhood in the UK, we have childhood panels and adult panels, and a lot of them are very similar. But it's just, it was really struck me, actually, that was really important. And it was a message I took home, actually, was doing teaching for some of our registrars in Yorkshire from the adult end. And actually, it was really important that I said, guys, if you have that epilepsy that starts in childhood, please do remember to send the childhood panel. Yes, you're going to send your adult epilepsy panel because that's what you're treating. But remember, this is a childhood condition that's now migrated and survived. And
yes.
Wow.
And you've got to be tenacious. And so on more than one occasion, you have to remove what sounds like a plausible alternative reason why this person's got an intellectual disability and complex epilepsy and replace it with the correct one. Because if you ask many people, was it a complicated birth? The answer is yes. Loads of births are really complicated. Prolonged labor and first... And if you're feeling that you need some form of explanation as to why is child number 2 different from child number 1, it can be returned to you, but it may not be correct. And so I'm quite tenacious. Early onset of seizures, I'm interested. If somebody said they've got cerebral palsy, but there's not a hemiplegia and the scan is normal, I'm interested. There's a story of, as I've mentioned before, being admitted for meningitis, but it was never really meningitis. What they mean is they were admitted for 2 or 3 weeks as the pediatrician investigated what was the cause of this mystery epilepsy illness. I'm interested. And, some of my adults still retain a fever sensitivity, and then I'm all game.
It comes down to the fact that we've got quite good at the pattern recognition. And I would say my colleagues in general pediatrics, especially those who have an expertise in epilepsy, really have got so good at the pattern recognition. Now they're highlighting to us early, going, this doesn't add up right.
Yeah.
But I think the patterns, as you said, the patterns have only really been there and described. And I think the other thing is we know the phenotype's expanding. I always think of the paper English Sheffers and did it was 2021 and 2022 that really expanded that phenotype.
Yeah.
And it's not just that kid who's presenting with a hemiclonic seizure, this prolonged and febrile. It's actually under 5 minutes, generalized tonic-clonic, that might have just been missed. And I think it's really interesting that we're seeing that phenotype expanding to put everybody on a bit more high alert. And then we come to the work that's been done by Amy McTague down in Grey Ormond Street, and how that has really revolutionized our early genetic testing, the rapid testing in the UK, which means that we're getting results back on some of the kids who've maybe been in with a prolonged seizure for weeks. And comes to almost Joe Simmons' paper, look at where he'd done the work in Scotland. And actually, there's a huge pickup rate for the kids who had the complex febrile seizures that were just a bit atypical, and actually probably more, who could have easily been labeled as an odd meningitis. And actually, I think that's going to change adult practice in 20 years' time. Do you think that originally many of these children who present with the focal seizures in the context of recurrent, continuous focal events would have been started on a sodium channel blocker? Do you think that the alternative strategies that we use as adult and pediatric neurologists with other medications has resulted in a different phenotype, a different natural history that means that they're maybe not picked up quite as well?
Yeah, I do wonder whether there's Dravet and then there's sodium channel, an early sodium channel modified Dravet, because if you look at the population statistics in terms of how often that gene should mutate, it pretty much marries up with Joe's paper. So we know how many cases of Dravet we should be expecting, how many we should be seeing. And try as we might, I can't find that many of people who have canonical, classic, textbook Dravet. And so that would be a really good way of trying to explain why there could be people who have classic sodium channel early bad outcome Dravet that I can see now, and then perhaps a von Frust, a mitigated Dravet, which will only be able to pick up in my clinic with expanded panel use, or perhaps differently, I'd probably need to go into other services to identify them. Perhaps they're in psychiatry as having an intellectual disability and challenging behaviour now, and the epilepsies are dim and distant parts of their history.
I was going to say, traditionally that LD CAMs, as in pediatric practice and obviously learning disability psychiatry, have done a huge and heavy burden lifting of epilepsy in that population group for decades. And there are that's the other group I really think would love to sort of come and listen to this podcast, is really because I think they are going to hopefully listen to this, and maybe there's going to be a few adults, LD psychiatrists going, oh, I've got a few of these. I know who I've got. I need to get them the Rhys.
Well, I mean, you've got a couple of options there. So one, you mentioned pattern testing, pattern recognition before. So, I mean, I'm not going to throw my colleagues under the bus, but 15 years ago, I went to some regional colleagues and I said, how many people with Dravet do you have in the box? And they said, look, in the whole region, there's like 3 million people. So there'll be 1 or 2. No, that's not the case. And now I see them speak at national meetings. They've got their eye in. They can't stop seeing Dravet as a clinical diagnosis because the pattern gets reinforced. The gene test tells you that you're correct. And so the pattern recognition is really important. But perhaps the question to ask, so if you're a psychiatrist with a large intellectual disability population, or if you're working in a care home for people with additional needs, it's either what is the cause of this person's epilepsy, or have they had a panel test in the last 5 years? And I think if you start with that curiosity, you might lead towards an answer for which one of the answers may be Dravet.
Absolutely. So it comes to a big question. Why is it important? I know for me, it's making sure they're on the right drugs and accessing the drugs early. But what difference does it make to your adult population?
Yeah, the differences are made across a couple of domains. So if I'm predominantly speaking to adults, and the family decisions are made. They're unlikely to be having more children, or the childbearing years are behind them. And so sometimes there's a family reason for, there's a cousin with autism, they want to know it's not related, or there's something like that. But if you can return to a family, no matter how old they are, and say, this wasn't your fault. This was a genetic accident, a genetic lightning strike that is unlikely to hit twice. And no matter you pushed a pram, the baby fell out and hit its head at the train station. That was one of the explanations that a family was told, or you fell down a flight of stairs. That this isn't the case. This was a genetic but not inherited phenomenon. So I think it's important in terms of explaining something so significant to families. And then the earlier you get it, more helpful it is for predicting the future. When somebody goes off legs and says, well, actually, that is the classic Dravet gait, and you've got to now watch out for their bladder function that might come next, and just knowing where you are in terms of stages. I think that's particularly helpful. But as you say, the really exciting thing about Dravet is it is probably never too late to be optimistic that if you get a really impactful seizure resolution that helps with encephalopathy that's driven by seizure, you can lift that encephalopathy, and you can get return of skills that you thought had been lost forever across a number of domains. And I work in epilepsy partly because I'm an optimist. I like the opportunity to stop seizures and improve outcomes. And therefore, Dravet is a really is a happy hunting ground for that, because you can have the occasional great outcome.
I think one of the things that always strikes me is, I've heard of adults in their 60s being able to speak by coming off a sodium channel blocker.
Yeah.
And that for me is the really exciting thing to hear. And just hearing that's more ubiquitously across multiple domains, it should really encourage us as pediatric neurologists, as adult neurologists, as as consultants who have a large intellectual disability population, both adults and children, to really pursue these genes and to really make sure that we don't have a Dravet on our hands. Because I know we've got a great network here in Yorkshire. As I said, I have a really fab network of paediatricians who have an expertise and interest in epilepsy. I have great geneticists who are linking in with me. We've set up pathways to try and get, as soon as an SCM1A mutation hits, I'm going to know about it. But we need that early buy-in, and I'm sure there are dozens of children I'm missing. And I dare say, very similar for yourself, my adult colleagues here, and for yourself.
Yeah, no, I very much agree with you. I wonder who else we could bring in as advocates. So it was a while ago now, but I was in clinic and I had a genetic test to return, and it wasn't a Dravet patient. And the mum said, before you tell me, can I have a guess? And I thought, well, good luck, because I had to Google this before I knew enough to be able to speak to you today. And she said, well, it could be Angelman's, because they keep saying it's Angelman's, but is it Christensen syndrome? And I said, yeah, it's Christensen. Why have you guessed that? She said, well, he looks just like the kid from 3 streets away, and they could be brothers, and he's got Christensen syndrome, and they're not related. And so I think there could be a little bit of allyship with parents out there. Perhaps there could be carers and parents and networks of people. You don't necessarily be an epilepsy specialist to be able to ask, could this be Dravet?
Where do you see the future of adult neurology with genetics and probably the wider DEEs?
Gosh, okay, here we go. So things are going to change. So the vast majority of patients who transition into our care will have had extensive modern genetic evaluation. And so I'm going to be less likely to be commissioning genetic testing for the first time. I'm going to be more likely to have a pre-segregated, pre-sorted adult population that would be eligible for treatment trials or will have had some precision medicine opportunities either offered in the past or available to them later. Over time, because we can't have a precision medicine approach for every variant and every gene, these are going to crystallize and consolidate into pathway approaches. And then there's still going to be a rare genetic epilepsies for which we don't have a clear single gene precision medicine approach, and we just need to support them as we currently do, pragmatically and using the least toxic medications that have the greatest impact for them. In terms of adult awareness of it, we're going to have to organize ourselves into initially regional and hopefully then more local centers where some of this expertise is retained. And I've got high hopes that the specialized commissioning document that's currently under review from NHS England might help to make some of these recommendations, because I'd love to work in a multidisciplinary team where I have access to some colleagues from genetics and from the learning disability team, physio and OT, psychiatrists, pharmacists and others to be able to provide a bit more holistic care, because being a one-man band, it can be a bit challenging at times.
And I think that's the one great thing about pediatrics is, despite us moaning that we don't have enough access, we have better access than our adult colleagues. So it's we do complain a lot about it, but we have a really great network. And I think that's one of the big things we do find within our transitioning population is they do have this and then suddenly end up on the doorstep of the adult neurologist and these things are lost. So it brings me to probably the last question you asked. I know how I get the kids in my clinic because they usually land on the PICU, in a tertiary centre, so it's very easy for me to pick up, or my local paediatrician with expertise in epilepsy, or learning disability paediatricians, developmental paediatricians, are keeping an eye, doing the genetics. But how do you get them in your clinic, and what kind of things do you want the adult neurologists, the learning disability consultants, anybody out there, how do you want them to come through to yourself and your colleagues who have that interest in the DEs?
Yeah, thank you. Yeah, I mean, every service is different, and I know that my service isn't mapped into every other region. Sometimes it depends on the setup or the interest of the individual. But I think that the types of people that I see, those people with moderate to severe intellectual disability, probably with autism, probably with multiple seizure types that are occurring multiple times a month, I think they all need to be seen by somebody. And if you can't find somebody who has a special interest, then you need to find somebody who is really interested, who will take you seriously, see you frequently, be able to chart your seizures, and then you can take on the care for these individuals by reaching out to other colleagues. They may be your pediatric neurologist who looked after them in the past. It might be a colleague in another region. And I just think these people need to be referred through. So the people get through to me through a number of sources. People think that I work in an ivory tower, it's hard to get into. But in reality, if you've got complex needs and tricky seizures, I say yes, because I'd love to see everybody at least on one occasion. And then we'll try and work out where in the region your care is best for the medium to long term. I share a lot of my care with specialist nurses across the region who are great. Many of them have got learning disability background. So I very rarely get a duff referral in. It's much more likely that people are holding on to people for too long before referring them in.
And they're probably sitting on a gold mine of patients who have genetic diagnoses, probably quite a lot of Dravet, who really could benefit from your expertise. Thank you very much, Rhys. It's been great having you. Well, that's it for this episode. If you love this episode, please share it with your appropriate colleagues. The only way this podcast is going to get out there is by you lovely people sharing it. So I would appreciate it if you could. And if you want to stay with me and learn a little bit more about Dravet syndrome, then please join me on the next episode. For now, I'll say goodbye and see you next time.